So now I'm going to talk about how to start uni in my practice. So basically there's nothing to disclose. Actually, when I got trained, I finished my training in 2014, and I was basically trained in knee arthroscopy and total knee replacement. But there was something in my mind which was constantly going, that there was some subset of patients in their 40s 50s which who have active lifestyle and very painful, sometimes failed conservative, even failed arthroscopy surgeries, and even I did few HTOs at that time, and even many of the patients were not too happy. So I was constantly thinking, and in 1450s I came to know about unicondylar knee replacement. But hurdles at that time were there was a limited implant option and a limited training. So it was a very scary thing at that time. And ultimately in my life, that miracle happened in 2016. This is my first uni after the training course of Oxford, and this was my first uni which I did in my practice. So after that, since then, from 25 surgeries a year to 250 surgeries a year now we have reached. So that confidence, due to that results of the surgery and in a very indicated patients, we could reach at this level. So what is the success roadmap, I would say, to start uni? So first thing is the confidence of surgeon. Be confident. Story begins here, because if you are not confident in explaining any procedure to patient, that confidence, if patient doesn't see in you, patient will never get ready to undergo that procedure. So confidence is the first thing to have in as a surgeon. Have faith in technique and technology. Get well trained. Proper patient selection and patient education. Give time to the patient, educate them, because not everybody would be explaining these things to all patients. So you need to give time to the patient, that this is the procedure, what are the advantages, why it is being done, and what is the scientific science behind that procedure. So what is a proper patient, as sir has already covered proper and nicely. So it is a medial compartment bone on bone disease with correctable virus, and in initial cases we should stick it to less than 5 degree FFD cases. Initially BMI, we may limit the BMI, but actually with time and with experience you may do in any case, irrespective of weight, near full ROM, and rule out inflammatory arthritis. So as seen in X-ray, this is a medial bone-on-bone arthritis, and this is stress view. So medial joint space is opening, skyline view is showing very good patellofemoral, and this is typical anterior defect. So in dead lateral view, if the defect is in anterior portion, that suggests that ACL will be competent. So what are the technical aspects from my side? So these first 2 points are pre-op, and then the rest of the 4 points are what we should do in intra-op. So proper patient selection, and as anyone have a doubt whether this patient is in the criteria, do MRI if any doubt, if patient has any complaints of instability or previous fall. So just to assess the ACL and lateral compartment, we may do MRI. So start with the minimum tibia cut. Why? Because we want to be in that strong subchondral bone, so the implants is not put on soft cancellous bone, and that may lead to subsidence or like that. So start with the minimum tibia cut. So we stay in the strongest bone. Appropriate lateralization of tibia. So we have more coverage of tibia. We are in the midline of weight bearing, so it is not loading on the edge, and chances of tibial condyle fracture are very less. Don't keep it too tight. This is not a deformity corrective surgery. So accept slightly loose and don't keep it tight at any point of time, and refrain from excessive slope because that may lead to earlier tibial loosening. So what my today's practice is, initially I was doing 100% mobile bearing uni. Now I do fixed bearing 80% and mobile bearing 20% uni. I do not have any access to robotics or computer navigation at present. And the encouragement which I got is from results, because patients are very happy with the procedure in a very selected patients. And in Gujarati, if you are able to do Garba at 15 days, then patient is going to be very, very happy. So I would in the last say, it's not just how to start uni in my practice, it's wow to start in uni in my practice. Thank you.